Assalamualaikum and good morning. Welcome to Breakfast at FOM live webinar series. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. So I can see there are about 25 over people logged into the webinar at the moment. You will have the opportunity to submit text questions or comments to today's presenter by typing them into the chat pane. You may send in your questions or comments at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Sorry, you can type in your questions at the Q&A pane. Yep. Okay, so first let me introduce myself. My name is Dr. Daliana Farid from the Department of Social and Preventive Medicine, Faculty of Medicine. I'll be responsible for moderating this presentation today, and I'm glad to welcome Dr. Nur Afiqah Mohd Salleh, who will present innovative services to meet the health and social needs of people who use illicit drugs. Dr. Nur Afiqah is the Senior Lecturer at the Department of Social and Preventive Medicine, Faculty of Medicine. Her areas of interest include social epidemiology, sociology in medicine, social and structural factors in health, HIV care outcomes, people who use illicit drugs, health information and database linkage. Some of the work that she will share in today's presentation was built on her doctoral research project entitled HIV Care Outcomes and Institutional Structures, Person-Centered Care for People Who Use Illicit Drugs. If you'd like more information about Dr. Nur Afiqah's biography, you can access our website at spm.um.edu.my. And now here is our presenter, Dr. Nur Afiqah. Please welcome. Over to you, Dr. Ika.
Thank you, Prof. Nick. I'll be sharing my slide, yeah. Is it showing?
Yes.
Okay. Assalamualaikum and good morning. Thank you, Prof. Nick, for the lovely introduction, and thank you for the organizing team of Breakfast at FOM for having me here today, sharing my insights on innovative services to meet the health and social needs of people who use illicit drugs. And a warm welcome and thank you to those who have tuned in to join us so early in the morning. My name is Ika, and what I'll be doing today is first to walk you through the global drug use pattern, just to keep us all updated on what's happening in the world as we speak. And I'll also talk a bit about the health inequalities, specifically among people who use drugs, and the relevance of social innovation in this area, and finally existing innovative strategies that kind of tackle these health inequalities. So the UNODC has estimated there are about 271 million people who use illicit drugs around the world. And every time I talk about these issues, I would try and make a point to say that it's really, really important to differentiate between people who use drugs and people with drug use disorder, because not everyone who use illicit drugs will experience drug use disorder, in which they become dependent on drugs to function and at this point may require treatment. And only 13% of the entire population who use drugs will experience drug use disorder. And the most commonly used drugs is cannabis, or what we call as marijuana or ganja. There are about 188 million of cannabis users, and we're talking about the illicit drugs here, not the licit types, meaning that these are prohibited depending on regions. And there's also a large number of those who use opioids like heroin and morphine, and these major drugs are followed by amphetamines, ecstasy, and cocaine. So what's happening now on top of the COVID-19 pandemic is what they call the opioid crisis in North America. And the number of deaths involving fentanyl, which is 50 to 100 more times more potent than morphine alone, has increased since 2011. And by the end of 2019, there were more than 71,000 deaths in the US alone. And it looks like 2020 will be even worse with the pandemic. And experts are saying that it's too soon to have a definitive data on the pandemic effects, but at least 30 states in America reported increase in opioid-related fatalities since the start of the pandemic. And the opioid crisis is of course challenging under any circumstances, but it becomes even more challenging during this pandemic because, as we know, with this pandemic, people are dealing with anxiety, grief, isolation, and changes at workplace and schools. And there are a lot of uncertainty around this, and unhealthy responses to these stresses would lead people to turn to substance use. And in Malaysia, instead of fentanyl, we are seeing a rise in methamphetamine use, especially among men, MSM. And now with meth pills being injected, we are potentially arriving back at this HIV and Hep C problem. And the meth epidemic in Malaysia also plagues other Southeast Asian countries like Thailand and Myanmar. So much so that the United Nations has found that the trafficking of meth is actually at alarming levels. And there's also a burden of disease associated with injecting drug use, where people who inject drugs are 24 times more likely to acquire HIV compared to the general population living with HIV through sharing of injecting equipment. And it is estimated that there are 17.8% of people who inject drugs living with HIV. And there is also a large burden of Hep C as well, whereby 52.3% of them are infected by Hep C. And 21.7% of them had recently experienced homelessness or unstable housing, making it hard for people to adhere to treatment regimen if they are started on HIV treatment. And 57.9, more than half of them had a history of incarceration. And there are 37.9 million people living with HIV, but the numbers have declined from 2.8 million in 2000 to 1.7 million in 2018. And we're seeing that 8% of people who inject drugs contribute towards new HIV infections. But although we are seeing a decline in the number of people who use drugs who are infected by HIV, studies have shown that they are less likely to progress along the HIV care cascade compared to the rest of key populations. And for people living with HIV, it's really important that they progress along this HIV care cascade right from the point when they are affected by HIV to getting diagnosed, to getting linked to HIV care, getting retained in HIV care and started on treatment, adhering to treatment and having their viral load suppressed, because at this point there would be a reduced risk of HIV transmission, reduced progression to AIDS, and reduced HIV-related deaths. And I'm sure you're all familiar with the 1990 goals, in which the UN AIDS has recommended that among those who are HIV infected, 90% of them are aware of their HIV status, and 90% of those who are aware of their HIV status would have started on treatment, and out of these, 90% of them would have their viral load suppressed. But what has been achieved by people who use drugs? Apparently, the HIV care cascade outcomes these data are limited for key populations, but existing data, they have demonstrated that the cascade outcomes among people who use drugs specifically are very low. And I'm going to talk a little bit about health inequalities. So when we describe health inequalities, we usually talk about the social factors, the education, employment status, gender, and ethnicity, and how these would have an influence on how healthy a person is. And in all countries, low, middle, or high income, there are wide disparities in the health status of different social groups, and this gives rise to health inequalities as defined as differences in health status or in the distribution of health determinants between different population groups. And factors that lead to health inequalities in the context of drug use, they can be multifactorial. there's this family history of addiction, socioeconomic deprivation, stigma that is attached to drug use, workplace policies that would terminate someone if based on urine analysis, homelessness, unemployment, gender, poor mental health, and also the systemic factors such as incarceration that limits people access to proper care. And this diagram is not it's not exactly describing the whole picture because the issues here are actually way more complex. And this is when social innovation may come in handy. And as I said, it's a very complex situation, and this is what sociologists term as wicked problems, and it refers to problems that are difficult to define and inherently unsolvable, and it's pervasive in the context of social and policy planning. And we also have different stakeholders with different views on how we want to address these issues. And these problems, these wicked problems, don't have simple solutions to them. And the complexity of these problems, the complexity of the problems in relation to drug use is reflected here in this risk environment framework within domains of economic, social, policy, and physical. There are problems of economic vulnerability that stems from employment challenges, isolation and internalized stigma, laws pertaining to drug use, and even the location of these services, whether these are brought closer to people who use drugs. And these are the multiple factors that place people who use drugs at risk for not only HIV infection, but also poor engagement in HIV care, leading to poor health outcomes. And it's a nice framework because in a way we are trying to move a bit beyond the individual's role in shaping their own health and looking at these overall environmental factors that somehow perpetuates health inequalities within this population. And coming back to wicked problems, the characteristics of these problems are often socially complex and rarely is the responsibility of only one stakeholder. And social innovation is seen as new and improved solutions to wicked problems, to wicked social problems, and it's really critical to kind of identify programs and interventions to address this complex array of structural and human factors, therefore calling for the need for implementation science. And if we really want to look at how we want to improve the health outcomes of people who use drugs and try to engage them more in healthcare, the solutions should be grounded on first harm reduction services and second treatment as prevention approach. And these two should be a collective social action, meaning that it's not the role, we're going beyond the role of the healthcare system alone, but involving multiple agencies as well. So I think we all know what harm reduction programs are. In terms of providing clean needles, clean syringes to people who are injecting drugs, access to naloxone to counter opioid overdose, other programs such as managing alcohol problems, the methadone maintenance program specifically for those who are using opioids, and supported by this the availability of peers that would help them engage in these many programs under the harm reduction pillar. And because antiretroviral therapy or HIV treatment has this secondary benefit of preventing HIV transmission through suppression of viral load. In 2005, researchers from the BC Center for Excellence in HIV/AIDS in Vancouver, Canada, they have called for this. They have advocated for this treatment as prevention strategy to end the epidemic based on the notion that early ART initiation following an HIV diagnosis could reduce the spread of HIV. And social innovation in context of harm reduction and treatment should be delivered through cross-sectoral and people-centered models of service design and delivery. And the CDC has proposed 3 areas or buckets of disease prevention. First, traditional clinical preventive interventions, and the innovative preventive interventions that extend care outside the clinical setting and involving the population, community-wide interventions. And the questions that we can ask are, how are these services being delivered? Where are these services being delivered? And who are delivering these services? And what we're seeing in Malaysia is this practice of scaling up methadone in community-based settings, in AADK facilities, and even in mosques in Pulau Pinang. And these are all moving away from the traditional healthcare settings like in government-run facilities. What we are looking at is, how certain organizations, they can expand beyond their core function. For instance, the mosque is becoming more than a center for religious activities, more than just prayers, but incorporating these kind of services for the community is actually one way to look at it, to look at how these services can be delivered to key population. And part of my PhD work was to look at these different locations in which harm reduction, specifically methadone and HIV treatment, can be co-dispensed together, and how this would have an impact on how well people are adhering to ART. So we've followed up participants and we've looked at the different locations where they're getting their treatments, in community pharmacies and in health clinics, in physicians' offices, even in HIV service organizations, the NGOs that are equipped with other forms of social support. And looking at this picture, they're also provided in retail pharmacies. And what we saw was that people who use drugs with MMT and ART HIV treatment co-dispensed at the same facility were 56% more likely to achieve more than 95% of adherence after adjusting for gender. And looking at this analysis, the analysis of co-dispensing serves as a proxy for shared values and norms that enhance congruence between MMT and HIV service providers, potentially through the acknowledgement of integrated services. And this congruence is actually supported by policies that call for the provision of both medications through a wider community in a low barrier approach, rather than restricting ART and MMT in their respective treatment settings. And how does this service-related social innovation through integrated care reduce the effects of health inequalities? So in a subsequent study, we've looked at how material security as a marker of poverty, as reflected by not having enough basic needs, not having enough economic resources, poor housing status, and how this would have an impact to how well people are adhering to ART. And the hypothesis that we had was that material insecurity, like not having these basic needs, would have a negative association with how well they are adhering to treatment. And we did find high levels of material insecurity in this population, especially in economic resources. And lower material security scores are significantly associated with experience of incarceration, not being able to access hospital, dentists, and optometrists, not being able to access peer group, not being able to access social workers, welfare workers. But surprisingly, we saw that despite the high levels of poverty among this key population, there was no significant association between mean material security scores and adherence to ART. And the lack of association between material security and adherence to ART may be linked to the role of universal access to free HIV medication in this context, as it kind of mitigates the impact of poverty on adhering to treatment, especially for those who may be experiencing material deprivation. And I want to link this back to the previous study on co-dispensation. What it means to have universal access is not only in terms of free HIV medication, but also how these services are being dispensed in a wider community sphere, potentially removing geographical and transportation barriers, especially important to vulnerable populations. On top of that, the needle and syringe exchange program, it remains the frontline of the harm reduction approach to reduce HIV vulnerability. And the key activities that are often accompanied, often embedded in this sort of program is the exchange of used needles and syringes for clean ones, safe disposal of used injecting materials, and reaching out and educating people who use drugs or people who inject drugs on HIV and AIDS and other related health issues through the work of peer workers or outreach workers. And this is something that has been done in Mauritius. The community container, a cargo type container that has been refurbished and placed in the community. And the aim of this project is to offer complementary services to ANSEP, the needle and syringe exchange program, including basic health services, case management services that would follow each client, and to link these clients to specific services, and provide a safe space for these people to come to provide counseling and support and referral services to various health and social services. And on top of that, they have this mobile programs that operate from a van or bus with needles distributed through a door or window. And these large programs also, large mobile programs also act like fixed sites with testing and other healthcare services that would, it is located in an area where there is a high number of people who use drugs, and will operate along regular routes at certain times, those hours when drug users are more likely to be on the streets. So it's bringing services closer to people who are in need of these services. And like our community container earlier, this medical caravan, it aims at providing needle on top of that referral to health services or specific social services, depending on what the client needs at that time. And this is a nice community health caravan from the Yale AIDS program in Connecticut, US. So they have this 40-foot mobile medical clinic that travels directly to New Haven, poorest neighborhoods that are impacted by homelessness, mental illness, HIV, illicit drug use. And what they have here is, mental health counseling, educational programs, on top of harm reduction and substance use services. They also have primary care, which looks at PrEP, glucose screening, and linkage to care, and they have this active case management as well. Other than that, they have these vending machines which dispense free kit with 10 syringes and needles. So what it does is that these vending machines are located in the community for people to get clean access to clean needles and syringes from these vending machines, with hopes that it will help prevent hepatitis, HIV, and other illnesses that are related to contaminated syringes and needles. And for drug users, for people who use drugs, to access to these clean needles, they should obtain an 8-digit code. So not everyone can get access to these needles. So they will be provided with a code to get these needles. So every time they will need supplies, they will go to these vending machines. That is actually quite convenient for them as well. And in 2003, Canada opened this first legal supervised injection facility where people who use drugs, people who inject drugs come to inject under the strict supervision of nurses and doctors and other healthcare workers. And other services that are being provided here, also referral to other related health services, including, providing options. If people want to enter treatment, they have these options to choose from. And despite being highly controversial with expectations that this facility would not last long, this facility is actually still running until today. Mainly because research has established the many benefits of a supervised injection facility, which has, open access to hidden populations, and in turn having more people in addiction treatment and other support services. It has reduced public disorder. People are no longer injecting in public. It reduced HIV and Hep C risk behaviors by reducing syringe sharing. It reduced drug-related overdose, and it helped save a lot of money resulting from overdose deaths and emergency medical services. And contrary to popular belief that it would actually encourage a higher number of drug use, there is no association between the use of this facility and increase in drug use in the community. And I think what's really key in this set of services for marginalized population is the provision of low threshold services or low barrier services, as opposed to high threshold services in which only 20% of active users come into contact with the providers. The characteristic of low barriers include removing structural barriers to services. It's community-based, it's providing service and treatment on the same day. And for those who are on NMT, they're provided with optimal doses, and it reduces waiting hours. And going down this pyramid, low barrier services attract a higher number of drug users, especially when these services are embedded in drop-in centers, in work programs, in youth programs, in outreach work, in supportive housing, and also mental health services. What I'm hoping to conclude today is that social innovation for marginalized population does not necessarily mean having advanced technology, but rather what are the creative, innovative ways, the approaches that we can do to kind of meet both social and medical needs. And these programs should be directed in the community, providing opportunities for government, health services, and other social actors, the NGOs, the for-profit agencies, and individuals to work closely with populations. Yeah, thank you for this short presentation. Over to you, Prof. Nick.
Okay, thank you very much, Dr. Ika, for that great presentation. So now we're going to open the session to questions and also answers, and hopefully Dr. Ika can address all those questions. Okay, so I can see one question here coming from Han Yang Chun. So he says here that you mentioned about overdose in the United States. How about the data in Malaysia? What is your view on how serious it is, the overdose epidemic in Malaysia?
Okay, as I've mentioned before, we don't have the similar situation in our country. Thanks for that. And but I think the overdose data, the number of reports on overdose would not be as high as in other countries, I'm assuming, but this sort of data, the overdose data is actually quite limited in our country. And this is certainly an area that we should be exploring more to identify what kind of interventions that we could have in place to support those who might be at risk of overdose. So I think there is a need to kind of strengthen the work that we do in terms of reporting these overdose. And I think, personally, I think it's underreported, unfortunately, in our country. Yep.
Okay, so while waiting for other people to come up with their questions, yeah, so I just want to know, like, how effective is the community-based methadone in our local setting? Like, what are the social challenges that stakeholders have encountered, and how has this been addressed?
Methadone in challenges in our methadone programs.
Yeah.
Okay. First, there's this issue of people coming in for methadone and leaving their jobs for a while just to come in, to get their daily doses. Because as we know, methadone is taken every day on a daily basis, and it's a problem for those who are employed. What does this mean for people leaving their work and coming to the clinic every day? Imagine that happening to us. Like every day we need to go somewhere to get our treatment so that we don't necessarily use drugs again. So it's a bit problematic for those who are coming every day and having to leave their jobs. So I think in terms of getting more support, but what we're seeing right now during this pandemic is that people are given 1 week takeaway instead of people coming in for daily doses. And I think it's a good start to start thinking of whether there should be a change in policy around providing methadone treatment rather than having a daily kind of services, but rather to have this more opportunities for take-home doses. Because at the end of the day, we don't want people to lose their jobs just so they can come in to take their methadone doses. And it's really important for these people to stick to their jobs. So these are actually some of the barriers that I've heard from the ground what's happening in our methadone context.
Thank you, Dr. Ika, for that. So, okay, next question is, this is a question from one of the attendees. So he or she wants to know if you anticipate that there will be such successful implementation of this social innovation in Malaysia setting, because it has already been very well received in overseas.
Yeah. Which social innovation? Are we?
In general, I mean the ones that you have already presented.
Okay, yeah. So the vending machines, the supervised injecting facility. I think we would need to look at doing a needs assessment to see whether if this is really a need among this population, and if it is, then we can have this kind. We could potentially open up a pilot project or something to meet these needs. It goes back to going back to community and assessing what their needs are, and whether or not having these services in place would improve their access to healthcare services, to harm reduction programs that we're talking about earlier. So basically, we need to do that needs assessment and follow up from there.
All right, so the next question is, this is from Munazira. Okay, currently drug use has moved on towards recreational drugs rather than the traditional drugs, which is heroin. So what is your opinion in how we can help in intervene this issue?
Sorry, can you say that again?
Okay, currently drug use has moved on towards recreational drugs rather than the traditional drugs, which is heroin. So what is your opinion in how we can help in intervene this issue?
Yeah. So with recreational drugs, people are more likely to use cannabis, and unfortunately, having these different categories, different types of drugs, our current laws have placed them under this one single act, which maintains that all these different categories of drugs have the same levels of harms, which place which actually place more people in greater harm, actually, especially when they're using occasionally, but suddenly they're getting caught, and in prisons they are exposed to these wider networks of where they can access to more harmful drugs like heroin and morphine. So I think there is a need to kind of re-evaluate our policies again to differentiate between recreational users and people who use other drugs like the traditional drugs have you mentioned, heroin or morphine. So there is a need to re-evaluate again our policies and how these different types of drugs are being valued or being viewed in our own community. And I agree, it's not going to be easy to look at these issues, and it really needs a good discussion on it.
Okay.
Yeah.
All right. So our next question is from Richard Ng. I think one of the challenges in implementing these social innovations is building trust among the marginalized population so that they are willing to come forward and access the services provided.
Yeah.
Do you agree with this, and how should we build the trust?
Yeah, I agree with that, because there is a lot of stigma and discrimination, especially towards drug use. And what we see in the media is always the negative narratives on drug use. So people are actually afraid to come out and to reach out to us for help. So I think the issues of stigma needs to be addressed in order for us to gain trust from the marginalized population. And I think we need to have ongoing discussions on what it means. As I've said earlier in the presentation, there is a need to differentiate between people who use drugs and people who are actually experiencing drug use disorder. And I think our society is not really clear on that, and it's really important that we start to educate people on these different types of drugs and the different harms that it brings to a person who uses drugs, to kind of reduce that levels of stigma, to gain more trust among this population.
All right, thank you for that. Okay, our next question is from Nadir. So he's asking that no doubt harm reduction has been proven to be successful in the Western countries. However, what do you think about our cultural acceptance here in providing vending machines for needles and syringes and free condoms, for example? So would it work in a local setting here, or we might have to think of other solution which is more culturally accepted?
So when needle and syringe was first introduced in our country, of course there was this big uproar saying that this would only condone drug use. Why are we allowing more and more people to use drugs? Why are we doing this? So in terms of cultural acceptance, I think of course there would be challenges in trying to shift our perceptions into be more accepting of these harm reduction services. But I think, as I've mentioned, this would need to be mentioned quite a lot in the media. This needs to be highlighted a lot. We need to debunk all the myths that are surrounding these issues of harm reduction. I think that would be the very first thing that we need to do, to highlight these issues more and more, and to have this conversation with the society and how we want to go about shifting our perceptions on harm reduction issues.
Okay, thank you. So yeah, so one of the approaches in the harm reduction program is actually the use of peer support. So yeah, I'm very interested to know how is this actually being done?
Peer support?
Yeah.
Okay, so peer support usually, in peer support programs, what they've usually incorporated is the peers, the people who use drugs. So we are getting people from the community who have shared experience with the community of people who use drugs to kind of advocate for better access to treatment, and they would have better understanding on these issues. They would know the lingo, they would know how to talk to this population, and they are the key players here who will be able to attract their other peers into assessing healthcare and assessing other health-related services, harm reduction programs, and they are very, very key in this whole idea of doing the harm reduction programs in Malaysia and in anywhere else in the world.
Okay, so this approach of course, has been tried in Malaysia in our setting.
Yeah.
Okay, and how effective do you think it has been using this peer support approach?
Yeah. So apparently there's not much, if you're talking about looking at studies that look at the effectiveness of having peer workers as someone to link this population to specific services. So this is actually still very underexplored, but to look at it in general, looking at monitoring data, programmatic data, we've seen a success in having higher proportions of people attending to treatment, assessing these harm reduction programs. But I agree that it needs to be evaluated using scientific approaches, and I think there's always room for improvement to kind of enhance these support programs.
Okay. Okay, so thank you again, Dr. Nur Afiqah, for answering those questions and for the great presentation. So are there any last words from you, Dr. Ika, before we end this session?
Yeah, sure. Thank you again for listening to this very short presentation on drug use and what it means for drug users to have these health inequalities reduced. And I think it's really, really important, and it's a high time to kind of bring this back to our social media and try to think about how we really perceive drug use, and what we as a society can help to reduce the stigma that has long been associated with drug use. And I think we should be keeping these conversations going and not stop here. Yeah, that's all. Thank you very much.
Thank you. So this concludes the webinar. Thank you all for attending, and we hope you have learned and enjoyed this presentation. Thank you for joining us today, and have a great day.
Thank you.
Thank you.